All right, I think most of the participants were able to join. So welcome everybody to this webinar hosted by ArtiQ and AstraZeneca. And tonight we're talking about smart spirometry. So just before we start, I would like to start with a couple simple housekeeping rules to run smooth tonight. So as a participant, you have all been muted. But if you have a question, please put a question in the Q&A box at the top. And then we'll handle all those questions at the end of the session with the speakers. If your question is already there or you see an interesting question from another participant, give it a thumbs up and then we know how to prioritize questions in the Q&A session. If you have colleagues that weren't able to join, don't worry, we will be recording the webinar and we will be sending you the link afterwards. So with that brief overview, I want to go to our first speaker of tonight. Professor Janssens from the University Hospital of Leuven is joining us, and he will be kicking us off tonight with a presentation about the importance of spirometry and the role it plays in the underdiagnosis of COPD. So Professor Janssens, please.
Okay, so I think I've shared my presentation. Okay, so yeah, thank you for the kind invitation, and I think it is really a pleasure to come back to spirometry for primary care physicians, and I think this has been a topic for more than 40 years, 50 years even of discussion, and still one of my favorite, personal favorites, and maybe the reason why I joined the pulmonology department here in Leuven a long time ago. So these are my conflicts. Most important is that I'm board member and co-founder of ArtiQ, and that I've also received research grants, consultancy and lecture fees from AstraZeneca, Belgium and Global. The prevalence of chronic respiratory diseases is clearly on the rise, and if we take this recent publication from The Lancet, addressing the global burden of respiratory diseases, I think it is clear that compared to 1990, and these are the plots at the left-hand side of the slide, almost all countries are reporting higher prevalence rates. In 2017, almost 60 million people are suffering from chronic respiratory disease, and this represents an increase of 40% as compared to 1990. So a huge increase, and in general, I think these increases in prevalence, as has been depicted here, are across all age categories, with mainly an increase in asthma as expected during child and early adulthood, but also with large increases and almost a disproportional shift towards COPD from the age of 40 years onwards. And this has to do with an aging population. This has also to do with a pandemic of tobacco smoking from the worldwide perspective, but also occupational exposure, air pollution, childhood infections, genetics, uncontrolled asthma, all factors that are now being understood as equally important as tobacco smoking for risk assessment of COPD. So COPD is no longer a smoking-only related disease. Only 70% of COPD patients has a clear history of smoke exposure. So there's many other factors. We also see a little increase in ILD, particularly in the elderly, but I think you would agree with me that this is only a minor fraction of an important disease, but that from a global perspective, COPD is clearly the main problem. And despite this pandemic of chronic respiratory diseases, we know that independent of the regional country-specific prevalences, and you can see on the slide all different cities across the world, that the majority of diseases remains undetected. And this is represented by yellow. These are the diagnosed diseases compared to the blue, the undiagnosed cases. And so the upper line of this plot shows the undetected cases, which range between 70 and 90% on average. and it's independent of the prevalence. You could, for instance, think that with higher prevalence, you're more easily going to detect COPD, but that is clearly not the case. So a worldwide problem in underdiagnosis of the disease. And as the diagnosis of COPD is still based on spirometry, I think that if we want to diagnose more early, and there are many arguments why we should go for more early diagnosis more frequently, you could almost fantasize about performing spirometry with every lung or health check. And unfortunately, these efforts on spirometry implementation would be huge. And that is why I think we should really restrict our efforts to case finding in populations at risk. And I'm taking you to a recent publication in the JAMA in which they used the capture tool for case finding. And the capture tool is not only addressing risk based on a history of smoking, so in line with our current understanding, it also assesses symptoms of breathlessness, fatigue, susceptibility for infections, hyperreactivity of the airways. And based on these anamnestic profile, they even add peak flows for people with intermediate risk, and presumably based on peak flow, address the impairment, unexpected impairment of lung function. And so if you pool them together with high-risk group, so people which have a clear link based on the questionnaire, then the benefits for spirometry become very clear. And this is shown in the following plot where when applying this stratification tool, it's shown that low and intermediate risk, so people with risk factors, but normal peak flow. So the people with low risk have detection yields of COPD around 6%, which is below what you would expect as normal prevalence rates of the population. In the high-risk group, however, and in those with intermediate risk, but with a reduced peak flow as a sort of second step, detection yields are substantially higher. And this is almost 20% of people detected with COPD. And what is also very interesting is that you see that 30% of these people present with a preserved ratio impaired spirometry. This is a new called PRISM pattern, which is a pattern that is known to be associated with an increased risk, for instance, for cardiovascular disease, but also with an increased risk of developing COPD in the long run. Important from this is also that we understand that despite this high risk assessment based on a questionnaire and eventually peak flow, that half of the population still has normal lung function. And this is really opposing against too much empirical therapy without appropriate spirometry-based diagnosis. So lung function is important to come to a diagnosis, and I think that one of the biggest differences, if we compare it with cardiologists, is that they apply their numbers. They use these strict cutoffs to address how and who to intervene. And we're not doing this. In the respiratory domain, we're still keen with general recommendations and advices on healthy behavior, and there is need for a shift in thinking. I think we need to be much more proactive and use our numbers as well. And so the numbers are there, and I can give you many reasons why spirometry makes a big difference. But because of time limits, I'll take you for one example. Here, for instance, we look at a heterogeneous data set of people that are community dwelling and people with a diagnosed respiratory disease. So in total, 40,000 people. And you look at lung function data presented as Z-scores, meaning scores that show how much your value deviate from healthy peers. And so the lower your Z-score, the more negative your Z-score, the lower your lung function values. And you can easily recognize that regardless of whether this is FEV1, DLCO, which is diffusion capacity, another test, or FEC, that they all associate and can work as important predictors because they associate with an increased hazard ratio for all-cause mortality, which is still a very important And so we have same data for spirometry linking to the prevalent risk of comorbidities and incident risk for developing comorbidities. We have the same data actually for exacerbations. And so where are we today? I think in general that spirometry is a cheap diagnostic test that can be easily implemented in primary care, and that it can either lead to the diagnosis and a confirmation of a clinical suspicion, to approve certain non-pharmacological but also pharmacological interventions. And it may also lead to appropriate referral to secondary care, because spirometry is key, but often, in some cases, they need to be accompanied with other tests to address fully the respiratory system. And so the value of spirometry for diagnosis and the diagnostic workup has been well demonstrated almost 10 years ago, time flies, by the Belgian pulmonary function study. And this was a study also published in Lancet, where based on 1,000 new patients that admitted to the hospital because of newly detected respiratory complaints, that we showed that clinical history, physical exam, and spirometry only was able to point to the right diagnosis in more than 60% of the cases. So it is really helpful in coming to a right diagnosis. And obviously, if you add on with other tests, then you improve your accuracy with almost 77% if you take complete lung function in these people into account. And so how comes then that there is still the underperformance of spirometry in primary care? And it may have to do, and I truly believe it has to do, with our organizational structure of healthcare in general, but there's probably other bottlenecks playing. And I think that first, the quality of the measurement and the maneuver is absolutely key to come to a successful diagnostic interpretation. And secondly, the interpretation of the test should not only look at a ratio or an FEV1, but should start from a good understanding of the physiology, so that we're able to extract more info from the pattern, the entire data set, to put it into the clinical context to come to a final diagnosis. And quality is a difficulty, because quality is sometimes based on rules, but certain critical mistakes can only be identified by an experienced person, a lung function technician or the GP. And secondly, the patterns that we need to identify comes in a bunch of data, numerical data, Z-scores, measured values, percent predicted values, and curves. And this may be confusing to some of you. And I think that ArtiQ truly has developed a solution that may anticipate to these limitations, and as such improves on the currently available technology. In fact, with deep learning algorithms, ArtiQ is now able to identify all critical errors and to instruct or guide clinicians towards an acceptable spirometry. And second, it also provides a description, an interpretation of the full pattern, which may help certain clinicians, and this might be you, in coming to a right diagnosis. And so with this, I'd like to hand over again to the chair of the session. Thank you.
Yes, so thanks a lot, Professor Janssens, for this great presentation already. I think it shows also, clear that the burden of respiratory disease can have, but also the importance of spirometry to really have an accurate diagnosis of patients with respiratory disease. Just maybe to also introduce myself. So I am Vincent van Heulen, I'm Medical Affairs Manager, Respiratory and Immunology at AstraZeneca. And besides the development of treatments for patients with respiratory disease, such as asthma and COPD, at AstraZeneca, we also have the bold ambition to reframe respiratory care by improving the patient journey. So therefore, we have been collaborating also with ArtiQ in this innovative approach in performing COPD case findings with the support of this artificial intelligence supported decision software, and this at primary care level. And thereby we also try to collect the feedback on how this software is really appreciated by GPs in the early identification and diagnosis of patients with COPD. So therefore, I would like to pass the word back to Professor Janssens, who will also elaborate on the results that we have obtained in this study.
Let me share this again. Yeah, thank you. It's me again. Same speaker. That might be boring, but anyways, we go for this. And thank you again for the invitation and to be able to present this collaboration between ArtiQ, between AstraZeneca and primary care physicians. And I was only helping from the back end to look at the data and to help in writing up the manuscript, which is going to be submitted soon. Aisah is a qualitative study focusing on the implementation of AI-based spirometry support in primary care practices. And the main objective, and based off my introduction in the previous presentation, we understand now that there is an important under and misdiagnosis often. And so the main objective was to better understand the limitations and the perception of primary care physicians on spirometry in general, which we consider as key stakeholders for future delivery. And secondly, we also wanted to evaluate how AI-based software can successfully be implemented in primary care to address its future potential. So in fact, this is a proof of concept study with a limited number of participants, but still with very interesting data, I think. So the study was a survey, was organized in different parts. It started with a survey amongst 18 GP practices. Some of you attending tonight probably participated, in which general questions on experience, perception of spirometry were raised prior to the implementation of ArtiQ.spiro software, which was uploaded to a computer that was connected to a Geratum spirometer that was given for free to GPs during the study. And so GPs were then asked to perform spirometry in at least 5 subjects, and we asked them as well to consider mainly individuals at risk for COPD. And so after every spirometry they performed, they, with help of the ArtiQ software, obviously, they were asked for feedback on a portal to address their agreement with the quality estimation and with the disease interpretation. We also assessed how many new undetected COPD diagnoses were made and not verified or adjudicated, because this was all anonymized data. So we were not able to go back to the medical records later on to verify this. And finally, it was a similar survey was launched basically to the same physicians to address the lessons learned. And of the 30 GPs participating, half of them reported to have limited experience in terms of time in practice. It was below 10 years. Apologize for the younger people. Half of them was very experienced with 15 to almost 40 years in practice. 21 on 30 of the participating GPs did not perform any spirometry during the last half year. And this may have been related to post-COVID period. I think that is probably one of the reasons. But also, I mean, it reflects that spirometry also in the Belgian setting is underperformed. 17 of 30 did follow a training course, but half of them, that was a long while ago. And that probably together makes that 21 on 30 find their training at this stage for both performing and interpreting spirometry insufficient. They also found themselves to have less experience or insufficient experience to perform these spirometries. And they said, well, and that is 2 on 3 said they don't use spirometry enough to really feel confident with the test. And this is also reflected in these pie diagrams. And in the left-hand side, 45% reported sufficient experience, meaning that 60 or 55% was less confident in performing spirometry. 35% only had sufficient confidence in the interpretation of the spirometry results. And this contrasted with, and that is on the right-hand side, with the answer that 85% of GPs really agreed that spirometry was key in their diagnostic workup. So despite they believe that spirometry adds, they underperform or they do not sufficiently perform spirometry in primary care. And this is a survey directed to GPs that are probably keen in participating to these type of experiments, so keen in using spirometry. So not really reflecting the overall population of GPs in Belgium. And so the barriers to spirometry that were perceived as most important were, and we took a circle around those, is insufficient spirometry training, insufficient personal experience, and logistical technical problems. And this is a bit counterintuitive, because I expected mainly to have as explanations limited time, limited financial compensations, but no, really this is to do with limited experience, limited praxis, and still technical problems. I'm cold, excuse me. So in the end, 150 tests were performed, and 144 of those tests, with the backup of the deep learning quality adjudication, were of high quality. So this is high, and this is even better as what we routinely have in clinical trials performing spirometry. So a high quality was reached with the software. And in general, if we then ask feedback of doctors after performing the spirometry and getting the diagnostic suggestion, they were sufficiently confident in the quality assessment, and they found the AI support useful. And similar findings were reported on the automated report and the disease diagnosis. And this was based on the average of a Likert score that was a 5-point Likert score, going from completely unconfident to confident and very useful at score of 5. In 123 out of 144 cases, the AI suggestion was also confirmed by the physician. So the physician agreed with the diagnosis. And when questioned whether the AI helped in the process, obviously in the majority of cases, this was confirmed. It confirmed their knowledge. But also, and this is interesting, I think, in 15 and 11 cases out of 123 or 144, I should say, it helped to further investigate a potential problem. So the software highlighted a disease on which maybe the doctor at that stage didn't think of. And so based on the AI most likely diagnosis, and again, I mean, this is not confirmed by going back into the medical records, 24 cases were detected with a new diagnosis of COPD, and this is 16%, so ranging between that 6 and 20% of the capture tool. They were COPD, but not only from mild stages. You could also see that there are now 7 out of these 24 had moderate, severe to very severe disease, undiagnosed. So still demonstrating that there is a lot of COPD community dwelling with no diagnosis. I think this is just a confirmation of what we knew since many years. And then finally, the general survey was performed again with the participating physicians, and surprisingly, 17 were still able to complete out of 30. Most often you get bored with filling out these surveys, but 17 completed. And although this might be too small to be representative, when compared to the baseline question in terms of confidence in doing spirometry and interpreting the data, there was a clear shift in those people answering to have more confidence and more confidence in interpreting and doing spirometry overall. So this brings me to my last slide, conclusions that although this study is purely qualitative in a subsample, and that is very important to mention, this is a subsample of GPs keen to perform spirometry more frequently, probably in primary care, we found that they all agreed that it has an important role and that they did not perform as much spirometries as they would like to do, despite the guidelines, and this is more because of lack of training, technical and logistic issues than time and financial constraints. 16% of new cases were identified, so again showing that spirometry has its role in GP if we want to tackle COPD more appropriately. And I think that there is circumstantial evidence now coming that ArtiQ.spiro can assist GPs in improving their quality and thereby coming to more appropriate diagnosis. And they agreed in 85%, which is not bad at all, I think, and provided them with more confidence in doing the maneuver and in interpreting the data. And so I think obviously this is the first step if we want to tackle this devastating disease in general. Thank you very much for it, and I'm happy to take questions. Thank you.
Thank you very much, Professor Janssens. I think it's very encouraging to see, definitely for us at ArtiQ, that the technology is positively accepted by the primary care physicians, and that we see there's more confidence and that they really see a support in the tools. So hopefully we can contribute with that to helping find more of those COPD patients that are being untreated today. So we're obviously also looking at more evidence, gathering more evidence, and another study we did in primary care in Belgium was together with the University of Leuven, so with Professor Verbakel, and he will be presenting us today the results of that study. It's a smart spirometry project that is looking at artificial intelligence supported interpretation of spirometry in primary care, again in Belgium. So Professor Verbakel, please.
Thank you. Can you see my screen now?
Not yet.
I think, let me try again. I think it's paused. Wim, have you stopped sharing?
Yeah, I think so. Yeah.
Click again.
Yes, now we can see it.
Okay. Yeah, there it is. So thank you for inviting me to speak here, and also for the collaboration so far. I would like to start off with just a bit of my background. I'm Jan Verbakel. I'm a GP by training and affiliated here with the Department of Public Health and Primary Care, and with a small honorary appointment at the University of Oxford within the Department of Primary Care Health Sciences. A few disclosures. I have a role as an advisor to the European Commission in the field of medical devices, and I'm also a member of the working group point of care testing of the National Commission of Clinical Biology. I still have a few days a week that I'm active in a GP practice in the Leuven area. I would like to start with this slide, where I believe that this project perfectly fits in this pathway. We see that often science, due to poorly managed insights, also poorly usage of the evidence and eventually capturing the patient experience, there are a lot of missed opportunities, waste and harm, potential harm to patients. And it's important, especially for technology, to look at the different stages. How does it perform in a clinical reality? What is the effectiveness of the technology on patient-relevant outcomes? What's the cost effectiveness and the broader impact? And this project that we've used and the previous project that have been presented today definitely contribute to better translation of science towards better patient experiences. And I would like to present this project here today. Some of the slides have been prepared by a colleague of mine, Sophie Willaert, a GP in training, who is finishing her GP training soon and has presented some of the results at the International Primary Care Respiratory Group a few weeks ago in May in Munich. Some of these numbers have already been presented, but if you look at the Belgian context, we know that about 1.2 million patients or citizens have a chronic respiratory disease. These are numbers based from our National Scientific Society, of which about 1/3, 400,000 patients, do not have a definite diagnosis. So there's a clear evidence gap there, or a clear need for better diagnostics for these patients. And there are clear recommendations on the use of spirometry in patients with chronic respiratory symptoms, but this is in large contrast with the actual use. It's not frequently used in Belgian primary care. So we know that in Belgium there are about 18,500 GPs. And secondary care consists of either patient-referred or self-referred. In Belgium, patients can self-refer to a pulmonologist, and we have also pulmonologists in tertiary care, such as Professor Janssens. We see that a lot of technical procedures are mainly prescribed by GPs in regional hospitals, so outpatient care, and depending on the local structure, spirometry, either with or without a consultation, can be offered. The big question remains, why do GPs or don't GPs perform spirometry? And previous studies suggest that there's a lack in confidence in performing and interpreting the spirometry. I provide a few references, and in the end of the presentation, you can find the actual studies. So this has already been shown in the previous presentation. Some of these technologies provides output that it's hard to interpret. You have to look at a range of rules to actually assess the acceptability of the test, but also the usability criterion, and the parameters that are produced are often difficult to interpret if you don't do it on a daily or weekly basis. So many parameters contribute to a complete understanding of the lung function. And although GPs are keen on learning and using these technologies, if you fail to do it on a regular basis, these numbers are difficult to interpret. So the role of AI is to bring that specialist level expertise into all levels of care. The actual objectives of this project were to evaluate the current prevailing ideas about the role of spirometry in primary care and the limiting and facilitating factors. So this is one of the studies within this pilot study that we performed, namely the qualitative work. The technology on the one hand, provides feedback on the spirometry execution, was it acceptable or not? And on the other hand, gives you complete interpretation and AI support for the diagnosis, as you see here, with the different potential disease probabilities to give you an idea whether the patient has asthma, COPD, or other conditions. So, as mentioned, the qualitative study was part of a larger study where we first handed questionnaires to GPs on their spirometry experience, their opinions and habits, and also performed semi-structured interviews to gain deeper understanding of why they do or do not use spirometry. Then we implemented the ArtiQ.spiro usage in those practices for patients meeting the inclusion criteria, and had first a short survey, multiple choice survey prior to the actual spirometry. Then the AI software provided feedback, and eventually a short multiple choice survey after the spirometry. At the end, we repeated the baseline questionnaire to see what the evolution was in terms of confidence. The diagnoses were made initially by the GP before and after the ArtiQ spirometry intervention, and also by a panel of pulmonologists at the end of the study, taking into account all the available data. So we get the results of the different stages in a minute. We'll first cover the methods. So first of all, there was a questionnaire where 28 GPs participated, 28 GPs working in 6 practices, and then 8 GPs participated in the semi-structured interviews. They worked in 3 practices. You have an overview of the participating GPs as part of the survey. The type of practice usually were more the group practices. There's an evolution in Belgium that there are fewer solo or duo practices, more group practices. The spirometry was only available in 6 out of the 28 GPs. 6 GPs indicated that the spirometry was available. And the number of spirometry tests performed in the past 6 months was quite low, with a median of 0. They obviously did not use the spirometer that often. So here you see the results of the questionnaire regarding the role of the spirometry. And most GPs agreed that it is a primary care investigation. Some also agreed that it's a more reliable test in secondary or tertiary care compared to primary care. Also, their confidence in using the different aspects of the spirometry, both the execution and the interpretation, was low for some aspects, and other aspects they thought they needed more confirmation of their clinical diagnosis through spirometry. The potential obstacles were quite numerous. They appreciate the fact that there was spirometry training, but it was not sufficient for most participating GPs. Also, the time constraints and the practical aspects for them was an important limitation of actually using the spirometer. So when we then moved on to the semi-structured interviews, we saw that the GPs summarized that there was a more need for objectification of the disease activity. So spirometry is perceived as useful, but they are unfamiliar with the procedure, although they received some training during their GP upbringing. But the actual performance and interpretation leaves a lot of room for doubt. And also the practical organization was an issue for them. There's limited time per patient, the actual material that's required, and sometimes calibration, and also encouraging patients' participation was not always easy for the GPs. If we then move on to the results of the pilot study, so the phase where we use the spirometry with the ArtiQ AI supported software as an intervention, we included 49 patients, and you see some overviews and some background information of those patients. And we saw that the clinical diagnosis, you see the clinical diagnosis on the left, that was a diagnosis before the spirometry was performed, and on the right, the diagnosis after the spirometry. There was some changes from the group that initially was thought to have asthma to COPD, so a smaller group with actual asthma and a larger group with COPD. And importantly, the confidence level of GPs increased significantly after spirometry. So you see on the top line, the clinical diagnosis, the confidence level was lower compared to after the spirometry. More GPs indicated that they were sure or very sure of the actual diagnosis. Then come to the usefulness of the AI-supported spirometry. They indicated that they thought the spirometry was useful for the diagnosis, and also the AI support was useful in both the performance of the test as well as the interpretation. So very much in line with the previous results found in the study by the previous presenter. So to conclude, the confidence levels in the performance and interpretation of spirometry of Belgian GPs is fairly low. However, practical organization limits the implementation as well. If we now look at the AI-supported software, it appears to increase confidence levels, but remind you this was a pilot study, and we still need to confirm this is in a large, for example, a cluster randomized trial where we compare the spirometry to usual care, the AI-supported spirometry to usual care. So here you see the list of references which you can consult after the presentation. And again, I would like to thank the partners. First of all, ArtiQ, who was kind enough to contact us to conduct this study, and also support, of course, from the province of Vlaams-Brabant, the area where we are working in. And this is the end of my part.
Thank you, Professor Verbakel, as well, for this great presentation on the pilot that was run in Vlaams-Brabant with the ArtiQ technology as well. So I think we can open up for Q&A. So I will probably look into the chat, and I see that there are some questions already in. So I would maybe start with the first question towards Professor Janssens. So can the artificial intelligence detect the unacceptable spirometry at the time of conducting the assessment?
Yeah. Well, I can look to people of ArtiQ, but because I think that during the study of Aisah, this was coming after the spirometry was executed, but that now in an upgraded version, they have it in real time available. So really looking at every blow, every separate maneuver, and giving immediate feedback on quality, not only selecting for acceptable maneuvers, but also for usable maneuvers, and giving instructions almost to perform it in a better way to the patient immediately.
Thank you. Maybe then I see another question, and maybe I can open the question to both, but maybe first to Professor Verbakel, because I see some questions popping up on how regulatory and billing code barriers can really be a challenge as well in certain regions. So what is maybe your reflection on that? Based on reimbursement for that, and maybe also reimbursement of the software, for example?
Yes, very good question. It is definitely different for different areas or different countries. In Belgium, there is specific remuneration for GPs to perform the spirometry test, either for just the spirometry or with reversibility. So especially in asthma patients, it's initially was set up to only be remunerated for GPs that follow the specific training in performing spirometry, but a few years ago, the accreditation or the training was no longer required to charge this code or this billing code. I think there's two parts to this. This first one is, of course, the accrual of the device, well, buying the device, but also the software, which entails a cost. And on the other hand, also the time necessary to train, to maintain, and to perform the test. So we trained and also keep up to date with the usage of the test, and also actually performing the test in your practice. There are some notions that we need to move from a fee per service system to more of an integrated system where the quality of care is promoted. And there are some initiatives where this could definitely fit. For example, if you look at your practice population as a whole and evaluate the care for the COPD population, where the spirometry was performed prior to start of certain medications, also outcome quality indicators would definitely contribute to better care. But at the moment we have a specific billing code for performing spirometry, and even then it's not used enough due to the difficulties in interpretation and performance of the test. And if I might add, one of the people at the forefront of implementing this training and also getting the requirements into practice is present at this meeting, Professor Buffels, who also had a question.
Yeah. Professor Janssens, I think you wanted to comment as well.
Yeah, but well, maybe I just add, and I was just surprised to see of the comment from Sanja Stojanovic, an expert in Canada, attending the session, that in the US, I mean, spirometry is only reimbursed when it is hospital-based, and so we're very lucky almost in Belgium to have it reimbursed in primary care. Obviously, AI won't take over the maneuver, so the performance of the maneuver will be reimbursed. And then the interpretation, because there might be different coding for the interpretation. At this stage, we solve this, that the interpretation is given as a suggestion. I mean, and this can always be overruled, and I think it should sometimes be overruled by a clinician. So it is the collaboration more of the suggestion with the clinician that comes to the right diagnosis. And so it's not taking over the role of the physician, nor in the performance of the maneuver, nor in the interpretation in the end.
Thank you. I see maybe two questions for Professor Janssens. The first one, I think, how many spirometries did you use to train the algorithm? Maybe I think we can keep that short, I would say.
Yeah, I think it was based on NHANES, and I don't remember by heart how many. There were many and plenty spirometries, and then it has been retrained on different data sets, but I have no exact number, but a lot of spirometries. And now shown to be superior to what human eye can judge. Because in clinical trials, for instance, you have an overreading of quality by human eye. And if you then compare it with the ArtiQ quality assessment, then it turns out to be superior even to that human eye. So it still makes mistakes, and any technology will make mistakes, but less as what an experienced quality adjudicator would do.
I think maybe this also partly answers the question of Johan Buffels, Dr. Buffels, but just to be sure, so yeah, you stated indeed that it's good quality of the spirometry maneuver is essential, but yeah, can the software guarantee this without visual control? So I can make acceptable and reproducible blows that are still sub-maximal.
Yeah, I think that he's referring to that inspiratory part, where you do a submaximal blow because of a submaximal inhalation, and it really depends on what the spirometry is transferring to the software, but the software is also able to look at the inspiratory part and therefore can adjust or look for appropriate inhalation to come to a maximal blow.
I see some other questions here as well. So maybe one for Professor Verbakel on also the guidelines and the ATS ERS standards maybe for spirometry. Do you think that they discourage further implementation or uptake in primary care practice?
I think not necessarily. If it's well implemented in the clinical decision support, I think this can be really possible to implement it. Those criteria are developed to make sure that we have reproducible results, and it's in line with the previous question. Actually, the software only supports you to decide whether a patient falls under certain criteria for a condition. And we've noticed that also during the study that if there's no clear sign, for example, for COPD and no reversibility is shown, still asthma has a reasonable proportion of cases, because it could be that you're just in between attacks or in between acute asthma exacerbation. So therefore, the clinical judgment still prevails, and I don't think the criteria necessarily limits the adoption. It's more the time constraints, the budgetary constraints, and the lack of experience in interpretation. Yes.
So thank you for that as well. I see some questions also around what kind of certification that ArtiQ receive. So is there any territorial limitation in the use of the software? And then maybe to add on that, to what spirometry software does it connect with actually? So maybe a question for Professor Janssens.
Well, on the first part of that question, I would like to refer to people of ArtiQ. They can probably take this.
Yeah, absolutely. So the full solution, so the support with interpretation is seen as the interpretation support is seen as a medical device in Europe, and so it's CE marked as a class 2A for the specialists among you. Medical device under the new MDR regulations, so it's also certified for that, and so therefore can be used in Europe entirely. We also use the AI algorithm that looks at quality control. Professor Janssens already alluded to it, sometimes in research settings, in clinical trial settings, to provide immediate overreading during those clinical trials. And that is something that is available globally, because that's not considered to need any specific medical device regulations.
Thank you. Maybe a question, and I open it for maybe the people of ArtiQ or both of the speakers. So have you used the ArtiQ software as well in clinical trials, and what's the impression of the Belgian regulatory agencies on that? Anyone, or Julie, maybe?
Yeah, I can give you some insight there. So we haven't done specific clinical trials on the software in Belgium. We are running quite a large clinical trial with the NHS. We have some people from the team there online as well, and there we work closely in the project as well with the organizations within the NHS, such as NICE, and there were also regulatory experts from the NHS looking at it to really make sure that they, that all the information that they want to know about the tool is being captured in those trials as well. So there's much more data that on the technology underway, We're very excited to share it with all of you further down the line later this year and next year. So I would say stay tuned for much more data on the technology in the coming months.
We maybe have one question more from the chat, and then maybe the questions that remain unanswered, we can still follow up on that afterwards, because we are almost heading towards 9 o'clock here in Belgium, at least. So one question from the chat is, on average, how much time does a GP need to spend for each spirometry session? And did you ask GPs whether time on a regular clinic day may be a limitation or reason for not performing spirometry? And maybe I would refer that question again to Professor Verbakel.
Yes, indeed, especially in the practice as a participator, we looked at the actual time spent, and it is disruptive for a routine clinical practice, depending on how your practice is organized. So with the reversibility testing, at least, you're up to 20 minutes at least for the test, and even with decent performance, it's probably a bit more. But we see an evolution towards practice nurses or nurse practitioners within the practice that can perform these tests and then consult the GP afterwards with the results to discuss treatment or management decisions. So I think this evolution will help to implement this technology. And as you say, within a busy clinic day without any support, it's difficult to implement any technology really. But with the support and better organizational structures, this should be achievable in the near future.
Okay, thank you. That actually also answered a question I wanted to add on that. So how you could indeed also implement this maybe at a broader scale at GP level, but I think you answered that well already. So I would like to thank especially also here the speakers for taking the time to present the studies as well. So highly appreciated, of course, from our side, but also I think from ArtiQ side. I would like to thank ArtiQ as well for setting this up together. So I think it's great to showcase what can be done also with spirometry and using innovative approaches to identify patients and diagnose patients with respiratory disease. And I would thank you, all of you as well, for attending this webinar. And I would wish you all the best for the rest of the day or evening, wherever you are.
Thank you. Bye-bye.
Yeah.
Thank you very much. Bye.
Thank you. Bye.